Perceive, process, perform. Do you need inspiration for your practice? Or do you simply need to practice inspiration? With this series, we aim to do both. Give us 15 minutes and we'll give you practice inspiration. Dr. Joel Rosenlicht, an oral and maxillofacial surgeon, has been in private practice and academics for 30 years, developing techniques for bone grafting, immediate impressions for implants, and prosthetic applications. In this presentation, he shares some of his seasoned experience on socket preservation.
Good afternoon. I decided that there's really so much good things and interesting things to talk about in oral and maxillofacial surgery, especially in implant dentistry, that some of the things that we do appear to be easy, but they're really complicated. And in order to be able to get an optimal result, I think you really need to kind of dissect out some of the things that make these easy procedures work. Because if you follow a consistent way of doing something, then the more challenging, more difficult procedures will follow. What I decided to do is to talk a little bit about bone grafting. Bone grafting is an extremely common topic to talk about, and more important than just bone grafting, we talk about ridge preservation, socket grafting. We can talk about the difference between inlay and onlay grafting, because they really are two totally different types of graft procedures, and there's really a tremendous amount of difference in how you approach those two different procedures. And then if we have some time, we'll talk about sinus grafting, which in a way is like an inlay graft. And inlay grafting is one of the easier procedures to do, and it's one of those procedures I think that should be done by all practitioners who are doing extractions and are trying to maintain structures of bone suitable for any type of prosthesis, including implants, or most importantly for implants. So, what is a bone graft and what does it do? It preserves the integrity of the existing bone. It supports the overlying soft tissues, the soft tissue components. It can support the gingiva, the papilla. Even if we're doing routine crown and bridge, it'll actually look better, aesthetically better, under those pontics and the prosthesis that it's going to be supporting. It maintains the osseous form and function of the areas that we'll be working in. And it gives the patient oftentimes an opportunity to take the time to decide what they may want to do in the future. Lots of times patients will come in and they're not quite so sure if they'll have an implant or what kind of prosthesis they'll have. And doing ridge preservation gives them that opportunity to have the time to be able to make the decisions and then be able to have the supporting structures to do the things that we want to do. So why and when do we graft? I think we should be grafting for dental implants and all prostheses. When we want to protect vital anatomical structures. When we want to prevent further atrophy and breakdown over time. And we want to ensure the aesthetics and the function for the areas that we're working in. These are all things that are very easy to explain to our patients. And once they understand the benefits of maintaining and preserving the existing ridges, I think they will go ahead and support you in your suggestion that you go ahead and do these things. So, how and when is bone grafting done? And why is it so confusing and oftentimes so challenging and complicated to do? How often do you hear different speakers talking about doing bone grafting procedures in so many different ways, and yet maybe even saying that they have the same or better results than somebody else? The answer to this question, I think, is pretty simple. Not all patients are the same, therefore they're going to react differently from the grafting that we're going to be doing. Not all graft materials are the same. We have to understand the different properties of those materials and how those patients are going to respond to those materials, and whether those materials are the ones that are most suited for the type of defect that we have. Because not all defects are the same. Not all surgery is done the same way. And you know what? Surgeons see things differently. What's successful to one person or one operator may be different than what another person sees as success or is in a way that they feel has been given a good job. I was shown this slide about 20 years ago, and it hasn't changed a whole lot. In fact, I'd like to give credit to the person who kind of showed me this slide, and it was Carl Misch. And it goes back, I think, to the early 80s, mid-80s. And at that time, it impressed me that he was able to express the sigma, or the lifestyle, of autogenous bone. And it was about that time that we were starting to develop a tremendous number of allografts as well as alloplasts that we were using for grafting material. And some of these materials had different periods of time to which they would either resorb or remodel or go through this sigma in comparison to what autogenous bone would go through. So we have a variety of different materials to talk about. And when we're talking about them, some are highly resorbable and are not there for a long period of time. Some are actually there for the period of time that autogenous bone would take to turn over. And then some of these alloplasts can last forever. They never turn over. So knowing the different qualities of the materials that we're using, I think, is critically important to the success of our grafts. Since the 80s and the 90s, we've been exposed to a tremendous number of new materials that have been engineered either synthetically or naturally synthesized. Gem 21, recombinant BMP, P15, platelet-rich plasma, PRGF, amniotic stem cells, other cellular materials that are being engineered, and a variety and a host of adjunctive membranes that we can use to really help ensure the success for a lot of these cases that we're doing. So it's important to understand all the dynamics that go around bone grafting and all the things that can be done to enhance the final result of our patients. So what's the criteria for a successful bone graft? Well, as I said before, understanding the material choice, I think, is critical. Sometimes we want materials to fill a void, but other times we want those materials to act as a scaffold. They have to maintain a certain form. They have to be there for a certain period of time. It's for those reasons that it's so important to understand the properties of the materials that we're using. The recipient site has to be prepared. More often than not, in the areas that we work in, we're working in very avascular areas. And we need a blood supply to turn these materials over so that our body has the ability to convert these allografts, either autogenous bone as well, into natural living bone from the host. Bone grafting really is no different than dental implants. We have to immobilize that graft. It can't be under any type of a micro or macro trauma that's now going to cause that graft not to integrate, just like we talk about implants integrating. So bone grafting needs a certain type of integration, just like a dental implant would do. These grafts need to be protected. We need to isolate them from foreign materials, bacteria. We want to protect them so that we ensure a blood supply and that these grafts can then grow and develop within the confines of that graft protection. You know, blood supply is so critically important to the success of our grafts. So the flap design, the way we prepare our incisions so that we can get a non-tension primary closure and assure that we're going to have good blood supply, not only to the incisions that we're making, but also to the underlying graft, becomes critical. So you should be thinking about the design of the flap actually before you even start the procedures. Vascularization is critical. Some of our patients are older. Some of our patients are younger. We work in large defects. We work in small defects. The time it takes to turn over these graft materials, the amount of time that's necessary to allow these different properties of these graft materials to take place can vary. In certain cases, on young, healthy patients, we'll go back into a socket graft within a couple of months to place our implants because we can expect the turnover to occur very quickly. In larger defects and older patients and immunocompromised patients, it may take many more months for those grafts to turn over. So as a result, it's important to realize that not all patients are the same, not all defects are the same, not all graft materials are the same, and we have to look at those particular instances individually and make the best decisions for those patients. In fact, when those patients do have a hard time healing because they've had failed procedures in the past, they have a poor blood supply due to any one of a number of reasons, they've been on immunosuppressive drugs or whatever, we may need to add some of these adjunctive therapies that we talked about before, the recombinant BMP, platelet-rich plasma, stem cells. All these things are adjunctive materials, as well as some of these membranes that we're using to help confine and protect our grafts. One of the worst things that can happen to any of these grafts is exposure. And once implants or once grafts do become exposed, then the likelihood of having an infection or the non-maturation of these grafts becomes much more significant. You know, we have two types of defects. We have filling defects, like a socket graft after an extraction, and we have building defects, those grafts that have to be added to the bone to actually reform or remodel what was lost over time. When we have a filling defect, these defects are defects that already have walls. They're confined and support for the graft. Oftentimes these defects are protected and they have a high degree of success because they're four-wall defects. They're sockets. Building a defect is totally different. Those defects may have limited support, may have a poor blood supply. They're subjected to overlying trauma, and these defects may need support to protect those grafts. So scaffolding, mesh, using rigid type of grafts, such as block grafts, may be more important in those types of defects. So, what's the most common graft that we do? And it's usually socket preservation. It's an inlay graft. It's a 4 or 5 walled defect, if you count the base and the 4 walls that surround that socket. As I said before, I think history is important. So do you know who and when first spoke about socket grafting or ridge preservation? It was in the late 80s that a dentist from New York who had developed this product called HTR, hard tissue replacement. You may hear of it. It's still on the market. He felt if you had a defect or took out a tooth and were left with a socket, why wouldn't you try to preserve that ridge for some future form? So Dr. Arthur Ashman actually started to coin the term ridge preservation or socket grafts. So why do we get bone loss after extractions? The clot's not maintained long enough for osseous maturation, thin buccal plate, less than 1 millimeter, traumatic extraction, disuse atrophy. Other overlying factors might be the blood supply due to the biotype or the phenotype of the overlying tissue. So socket grafts are relatively straightforward, but their indications, I think, are all extraction sites, all surgical sites where implants are contemplated and the ridge is deficient. Contraindications might be severe localized bone infection, uncontrolled periodontal disease. Patient can't afford to do it, but as a referring practice, can I afford not to do it to encourage my restorative dentist to be able to now talk this patient into having what might be most appropriate, which would be a dental implant? So the surgical technique is an atraumatic extraction, thorough debridement, loose compaction of the graft, possibly an overlying covering of collagen or a TefGen membrane. And if needed, we can then protect that with either biofoil, periodontal packing, or the prosthesis to help form some of the ridge contours that we're trying to do. So here's an example of a fractured tooth that's non-restorable. Atraumatic extraction with periotomes or power tomes. Filling that defect with loose compaction of a composite graft. In this case, we're using a combination of an allograft and an alloplast. And here you can see the debridement, the covering of the TefGen membrane and the sutures that are overclosing it. Our removable prosthesis to help develop that emergence and the ridge form that we would like. And then at 3 months going back, we can see some of that graft material and how it's beginning to undergo its maturation. And this is just prior to the implant placement. In this particular case, we used a combination of beta-tricalcium phosphate with some, I think, local autogenous bone in a 50-50 combination. We covered it with a membrane of collar plug and then covered that with a TefGen membrane. Over time, we want some of these materials to resorb. And here you can see some of this beta-tricalcium phosphate over time, after the first week or 10 days, starting to undergo resorption and remodeling. And here you can see the new bone forming around these particles of resorbable graft material, so that over time when we go to place our implants, we've got a good vascular supply of natural bone around these implants to ensure a much better integration than would have happened if we used materials that would not turn over or turn over quite as quickly. So as you can see, socket grafting in and of itself is a relatively easy procedure with very, very predictable results. But there's a tremendous number of things that you need to think about when we think about doing socket grafting, as in other kinds of grafting. We need to truly understand the type of defect. We need to know our patient and what the medical problems they may have. We need to select the proper graft materials and adjunctive materials to make that work well. Bone and soft tissue grafting can be challenging. Do one thing at a time, most oftenly, to ensure success, and follow good surgical principles. Thank you.